Welcome again. Thank you so much for joining us for today's call from Aid to Agency, How Africa is Leading Its Own Health Revolution. My name is Erin High, and I am a development officer here at Amref USA. Now, I am honored to introduce our featured speakers for today. So we have Dr. Githinji Gitahi, who is our global CEO. And also we have our Amref USA CEO, Bob Kelty, joining him. So I will pass it over to you, Bob. Bob, you're muted.
Sorry about that. Well, good morning, good evening, good afternoon. We have a lot of folks from many different places around the world. So we're very excited for this conversation about from aid to agency. I'm very excited to have a conversation with my good friend, Dr. Gitahi, Githinji Gitahi. Want to put a little historical context on the conversation so we don't kind of start at this moment because it's been a long time coming. Githinji and I started roughly the same time, about a little over 10 years ago at Amref. And it was during that 10 years, Africa's seen, or the whole global world has seen, global health has seen major disruptions. When we started, it was during we first joined, it was during the West Africa Ebola outbreak. And during that period, the Ebola outbreak was in West Africa. And when I started, first thing I noticed was that when I went to meetings in New York, the UN donor meetings, there was no African representation. So you had an outbreak, you had a major modern health crisis on a continent, yet there was no voices there. And how do we work? The funding that went to organizations went to U.S. NGOs, bilateral organizations, the UN, and only less than 2% went to African institutions of almost $3.5 billion. So no money went to Africa, no real decision making went there. And so it was very, going to these meetings, and not seeing anyone from Africa there, not hearing from anyone from Africa. Eventually, Amref did get some funding, but it was actually not from institution. It was from two individuals who gave us funding so we could start our work in Guinea. So I'd love to start with the first question. Githinji, you started, during kind of middle of the Ebola outbreak as it was unfolding. How did it feel to take leadership of the largest African health NGO at that time? What were you thinking? What was your reactions?
Yeah. Thank you, Bob. And a good question. At that point, of course, excited to be part of the mission of creating lasting health change for Africa. I had come from a background of clinical practice as a medical practitioner, as a healthcare worker in rural areas of Kenya. I had also worked closely with the private sector and I had gone to development. And I was looking forward to this organization, which I was very proud of, where we could make impact. But as soon as I joined, we had some conversations with the Africa Union at that point. There were hopes that we would create institutional capacity across the continent to work together with, because Amref has always been a partner of the Africa Union. And then the Ebola crisis happened. And Bob, I remember us talking because I went to the Africa Union and I was trying to see how can we respond quickly together to the crisis that was in Sierra Leone and the other countries in West Africa. And as we were doing this and we had a plan, we knew that we wanted to ensure that Africa itself could assist its member countries like Sierra Leone to respond, put health workforce in the front line, be able to do surveillance quickly, be able to engage communities and make communities the center of the response. We had no resources. And we found that the government themselves, of course, were in emergency mode, so they had no resources. We tried to do a bit of getting volunteer health workforce to get there. We had challenges of mobilizing them because of resources, and we tried to raise some money. But what was sad then was it occurred to me very early on in joining and leading Amref that actually the focus of the available money for response, for surveillance, for emergency was not available for local organizations. It was largely given to organizations that were traditionally largely American, but also international from other countries as well. And I think this is what struck me. And that left me a bit disappointed. And I was saying, how do we then create the capacity to do the response for ourselves? Because self-reliance is not a luxury, especially in a pandemic or an outbreak. It is actually a necessity to have self-reliance. So that was my feeling, which was kind of a sinking feeling at that point. But I was hopeful that we could change this, Bob. That's how I was feeling then.
Yeah, and one of the things also that really struck me, the countries, the organizations that knew how to deal with Ebola had, it was Amref. In Uganda, we had dealt with it. In, DRC, the first actually organizations in the field in Liberia were universities from Uganda. So this expertise of how to deal with, Ebola, Africa had that. And, so I guess my question is, also, what were you thinking when you realized that no institutions were involved? How did you kind of start thinking about this? As the crisis came to, I think the crisis ended, it was officially over in 2016 in June, I think, but by the tail end, by January, it was pretty much over. So like during that period, I know it struck you because we talked about it. It's like, so what would it look like the next time there was this kind of outbreak? And what was your thinking around it?
We knew, let me just sort out my sound here. We knew, Bob, that from what we had learned in the response to Ebola, we knew that the most impactful response was response bottom up, that it needed preparedness of communities, because in every case of an epidemic or a pandemic, it starts with an index case in a household. It starts where the first infection arises before it spreads to other people. And therefore, you can imagine that if I lived in a house, and considering Africa as one house, and there was a fire, and I did not have the capacity to respond to the fire from where I live, and I have to wait for people to come and respond to the fire, then there is a problem already. And that is what I felt. I felt, how do we now, as a leader of a truly indigenous African organization working with multiple countries, what kind of systems do we need to put in place to ensure that our internal response will not need to wait for our friends to come, that we will start it? But the fact that we start doesn't mean we'll do it alone. We'll do it with others, but at least the response will have to be, like internally driven and inside out. So that's how it felt. And therefore I started asking myself the questions about how do we build this capacity with the government? Because again, it's not something you do as an institution like ours on your own. How do we build this capacity? First, community by community. We work with communities to strengthen their own response to disease, but more importantly, to actually strengthen their own health, so that disease is an outcome, is what may happen, is an emergency, but health is really what we are building. So how do we build this community? So we start to talk about strengthening community health systems across the continent. We start to think about how to work together collaboratively with Africa CDC, because you will remember that at this point of Ebola, there was an accelerated impetus to now put the institution of Africa Centers for Disease Control and institutionalize it because of the experience of Ebola. So now we were thinking, how do we strengthen the African institution to respond? So we got involved with Africa Union. We started to develop the structures of Africa Centers for Disease Control. We actually got involved in the original governance of creating the Africa Centers for Disease Control to prepare. But we didn't just end up at this institution or regional institution. We started to work with government to talk about disease surveillance, community empowerment. We started to talk about the need for domestic resources to mobilize international resources and diversifying the people who could help us respond. So we started to talk about to individuals, Bob. You remember, we got high net worth individuals to step forward. We got governments to start to engage with us. And this is what we started to build toward the future self-reliant health system. But I can tell you that this dream was not easy. It is still not easy to date, but I can say that we've walked a long journey to get where we are. But that was, the thing was, how do we build the future health system that is self-reliant, that is actually dependent on the capacity of communities to respond to their disease threats, and therefore by having a good response, then they would save the world as they save themselves.
Yeah, I mean, I think it's a really great point. And you look at the next kind of steps the international communities took after Ebola around health security. There was finally actually an investment in community health workers, in that community-based surveillance, disease surveillance. And I think it made a difference. And I think it's something, because, after the money stopped, after the, Ebola crisis was over, I know we came in and invested money in Sierra Leone because they lost so many of their doctors and so many of their nurses and their frontline health workers. And again, that was in a partnership with the African Union. I think that was one of our first initial partnerships. And because the thing with the crisis, especially when it affects the rest of the world, as soon as the crisis is over, they walk away. And so I guess the next major disruption was 5 years later when the COVID outbreak happened. And we'd love to hear what was the difference between when the COVID outbreak happened versus Ebola? What was, were African institutions involved in that? What was the response? Or was it again left to the richer countries in the north to do the response?
So the first thing I want us to reflect on is that what we have memory of is the large Ebola outbreak in West Africa. The reason that became large is because the world was threatened, that actually the virus got a passport to travel, and it traveled to countries which felt that their health security was threatened. And that's how they mobilized such huge amount of resources and used what I would like to say, the channels that were not fit for purpose for the response, because the channels that were fit for purpose would have been to direct that money to the local communities so that you not only respond to that particular crisis, but you build capacity for the next one. So after that, what happened is that many Ebola outbreaks have happened since then. I'm sure not many people in this meeting would know that after the large Ebola crisis, we've had an Ebola crisis in 2018, 2020, 2021 in February in Guinea, again in 2022-23 in Uganda, and DRC. They have been ongoing. But the reason we haven't heard about them is because the virus hasn't been able to travel out, which means that these threats are constant. They are constant, and therefore the capacity of the local community to respond is actually what's most important for security for everyone across the world. So we continue to build this security. And in one of the Ebola outbreaks, Bob, you probably have seen this, we've discussed this with you, and this is the Ebola outbreak in Uganda, 2022-23. Because of our ongoing work in these multiple countries, including West Africa, East Africa, Southern Africa, during this Ebola crisis in Uganda, Tanzania government, working with, at that point, the US CDC and Amref, started to train community health workers. We trained community health workers to respond to any Ebola crossover from Uganda to Tanzania. So we trained them to do border surveillance. And these community health workers, whereas they were trained for what we call event-based surveillance for Ebola, they use that knowledge to actually discover the incoming outbreak of Marburg virus that helped the Tanzania government to respond to it before it became a global phenomenon. These community health workers we trained, a 21-year-old female community health worker who had been trained, is the one who noticed that there was something going on in our community and therefore raised the alarm that enabled the Tanzania government to respond to the Marburg virus, speaking to the fact that it is the community response when capacitated that is most significant. But we continue to do this. So that was one thing we did to build community surveillance. The second thing is when COVID came, we were building our community capacitation over and over in most countries, but we had also invested across for the institution, Africa Centers for Disease Control. So we saw when COVID came, there was a much better institutional coordination across the continent. I would like to say because of Africa CDC, we had 7 presidential level meetings to discuss the response to COVID-19 because of the institution of Africa CDC during that period. The next thing we saw is that we were able to activate community health systems to engage communities in social distancing where possible. And because in many places it wasn't possible, the community health workers knew why it was not possible, and therefore were able to apply the public health advice based on context. We saw community health workers mobilizing soap and water for communities, but also making communities understand. And even when vaccination came, it is the community health workers that were going to encourage this to happen. But we noticed that the same global health structures that we had seen fail us in Ebola were failing us in COVID-19, Bob. We saw that whereas we had built institutional response and capacity, whereas we had continued to invest in community health workers, the response to COVID-19 demonstrated once again that self-reliance was not a luxury. Because whereas we had discussed this and we had built institutional capacity, 100% of the COVID vaccines that were going to be relied on to save lives in Africa were actually coming from the global north. And when the global north felt threatened, they locked their borders, they closed their borders, and they hoarded the vaccines. And we saw significant, what I called at that point, vaccine appetite. And because of this, Africa now had to learn new lessons that actually, even as you build your own capacity, you must also be in charge of your own supply chain. You must also improve your health systems to provide for the supply chain that will be necessary for response in danger. And this is not only for Africa to preserve itself, it's for Africa to be part of a distributed capacity for global health security for everybody. So the same global health structures came again to actually create inequities between the global south and the global north, even as the global south had been on a journey of building its own capacity.
Yeah, I would just like to add to that. I mean, you saw 3 countries were affected by Ebola. Africa was not really part of those responses. But during the COVID outbreak and the vaccine effort, even though vaccines were very slow to come to Africa, Amref alone worked with 45 countries to mobilize, to distribute vaccines. So just the jump in the ability to actually mobilize the health systems of Africa was, for me, looking at it from the outside, was dramatic. And I think, long term is that investing in the strength of health systems is, that first step, whether it's a primary healthcare system, to making Africa independent. But, so I think there was, maybe just talk a little bit about that progress and how much was made just internally in Africa, because I think it's pretty dramatic. And I think that's an important thing that when we're talking about what's going on with Africa, that the successes too.
Yeah, and thank you for that, because you see, the thing is that when something like a pandemic like COVID-19 happens, everyone gets locked up where they are. And therefore, people depend on the resources that are available to them. And that's what happened during and after during the first response of COVID-19, and even when the vaccines finally became available, people relied on their own institutions to do this. And Amref, after the capacity we had been building, the relationship we have built with government and Africa Union, when the vaccine finally came, and even before, it was us who were relied on by governments to build the confidence and the trust on the vaccines, to overcome vaccine hesitancy, to train frontline health workers, including nurses and community health workers, to encourage and to ensure that people could access vaccines. We worked in more than 40 countries to deliver COVID vaccines and to integrate them with general routine vaccination. We delivered more than 17 million doses. We are still working with countries to ensure that they can actually integrate all these new innovations of vaccines, not only for COVID-19, but future ones, into routine vaccination. And this is the thing about building local capacity, that when you build local capacity, it's available 24/7, 365 days. But when you rely on external capacity, it'll only be available when the circumstances and the conditions are enabling for its availability. But if your capacity and your partnership is with your immediate community, then it will always be up to this up to up and ready whenever you need it. And that's what Amref Health Africa did as a truly indigenous continental agency that is in almost 40 countries across the continent. So building our capacity is actually enabling communities and local capacities to work.
So when the vaccines were delayed, not coming, and afterwards reflecting back, and you talked to one about the supply chain, but also how did it affect, I think vaccines being delivered through Gavi was always something that always believed in, that those vaccines were going to be there. And this was the first time that vaccines were not delivered in a timely manner. Part of it was because the vaccines that had been delivering before were not new vaccines. And so how did it think about your strategy moving forward, that could you depend on, one, not just the supply chain, but in the future, did Africa need to start changing its strategies and looking at support from the North in a different way?
I think where we are, and now I can relate this to also evolving changes in global health. Post COVID-19, we've seen other significant events that answer this question, Bob, that you're asking. We've seen the US withdraw aid development assistance significantly. Not only the US, we've seen others do the same. And therefore, the experiences of COVID-19 and the experiences that we've had in the recent past have resulted in a movement across the continent. And this movement is not only institutional, it's also the people themselves. It's the people, the young people, calling about sovereignty, saying the governments can no longer continue to have the health agenda of their people led from the global north, that the governments have to work with their local civil society, they have to work with their available domestic resources. But that doesn't mean that when they work with their own agenda and their resources that they work alone. They will still need partnerships. And those partnerships will come from individuals, foundations, will come from other governments, either multilaterally or bilaterally. But the overall call is for health sovereignty, Bob. It is African countries saying, let us own the agenda, because our learnings of the past are that when the agenda is owned by us, then every partner we get, every dollar we get from outside is catalytic of our own resources and build a health system for the future. So we've seen multiple conversations. We've seen the president of Ghana leading a conversation on Africa's health sovereignty. Amref is involved in that. We are supporting that effort of the president of Ghana, President Mahama. We've seen African Union and ourselves rally behind a common agenda to ensure that assistance is respectful, that assistance recognizes that actually knowledge from the communities is part of the first asset of ensuring strengthening of health systems. More recently, we've seen an agenda for global health reform, where we are discussing with young people, the young, the old, civil society, governments, private sector, to say, how does a future sovereignty for health in Africa, led by Africa, but supported by respectful partnerships look like? So the first thing is to ensure that we are building strong primary healthcare systems. That primary healthcare is the foundation for health, is the foundation for global health security. So a good primary healthcare system in Chad, a good primary healthcare system in Djibouti, a good primary healthcare system in Malawi is actually a safe world, because the health of all of us is dependent on the health of the weakest health system. So building primary healthcare that's dependent on enabled and empowered communities, dependent on a working primary care and early diagnostic and surveillance, and dependent on a health workforce that is context built, and depending on environmental conditions, that's multi-sectoral action, ending poverty, availability of water and sanitation, availability of nutrition to children, is the health system that's going to keep the world safe. And now, right now, even thinking about climate change and the impact of global warming on the health systems of poor communities in Africa that have a very little to do in terms of contribution to the carbon emissions, but being impacted significantly by global warming and seeing more recurrent cholera outbreaks, more recurrent extreme weather events that are destroying their crop, and therefore there is severe malnutrition and rising other diseases. So I think building a good purpose-built, community-led and people-centered public primary healthcare in the continent, adding that onto that, more domestic resources that we are working with governments to ensure they get into the health system, and ensuring that global partnerships are cognizant that local capacity is the centerpiece of building global health security. I think those are the things we are moving forward to build, and Amref is at the center of that conversation.
Thank you. Just kind of focusing a little bit about Amref. So we made some decisions after COVID on how we were going to look at our resources, how we were going to generate income, and trying to kind of scale back. I think we reduced the amount of U.S. government we were receiving by 40%. We made investments in the university, or creating a new campus. Maybe talk a little bit about the thinking of how Amref kind of knew or was looking ahead to need to adapt to what could be a changing environment.
In 2015, I came in, and it was a coincidence that when I was coming in at the same time, the Millennium Development Goals, which were designed by the UN and funded largely by governments like the US government and others, which are focused on specific diseases, HIV, TB and malaria, reduction of maternal mortality, reduction of child mortality. They were very, very specific, were coming to an end. That 15 years ran up to 2015, and they were coming to an end. And at that point, it was very clear that what we're discussing now was actually a more holistic strategy of sustainability. And that sustainability was saying that aid is important, but even more important is how to mobilize domestic resources. And in fact, at that point, Bob, it was very clear that if you looked at a country like Kenya, or Tanzania, or Uganda, or Senegal, you would notice that whereas the health systems were weak and were weakly funded, the majority of the resources that were funding the health system were actually local. It was government, individuals, and communities in kind. But the donors were still a critical part of that health system and were contributing about 20-30%. So the sustainable agenda was then asking organizations like ours and governments to say, how do we harness these blended sources of data, of resources? How do we diversify so that we are not just looking at the donor element in ensuring health for the people? And Amref started to look at how do we actually diversify so that we still continue to work, with a very important element of development assistance, structured development assistance that is based on global solidarity and responsibility, where governments have committed to provide at least 0.7% of their gross national income to development assistance to ensure equity across. As we know, aid is really not charity. Aid is actually a tool for social justice and equity. And this element is important for us to continue to focus on. The second element is to build what we may call social enterprises. Because even in the continent of Africa, we have a rising middle class. And that middle class can actually still provide resources if the instruments through which they're providing the resources are purpose-built. So we thought of creating a tool for training health workers, because Africa has a shortage of health workers. How do we actually provide a platform for training health workers to provide services to the people, assisting government to close the gap, and ensuring that the middle class can provide part of the money, and that money can then be used to subsidize the poor. And therefore, we are creating an institution that provides health workers who are not trained purely by donor-driven resources, but they're actually using resources from Africa to cross-subsidize, to get the poor and those who are rich together. And this university now has close to 4,000 students, nurses, midwives, physiotherapists, people who can treat, who can support cancer. We are moving into, areas of disease prevention. And these students are being trained on money available in the continent through this cross-subsidization model. This is growing very rapidly, and we see the university in the next, by 2030, being a significant part of our work as a critical element of our resource mobilization that is having the continent without having to be dependent on donors. So that's one area. And therefore, we are encouraging our supporters support that growth. The second one is, of course, converting our existing resources and leveraging them to bring us more resources. We know, many of you know, that Amref for the longest, for the last 8 years, has had an air evacuation service that provides air evacuation services for the poor, but also delivers services to those who are farthest away from the center, from the capital. And this Amref flying doctors, because we have assets of flying, we have aviation assets, but that we have for providing these services to the poor. We then start to ask, who else will need these services, can pay a little money for them, and by paying a little money for them, they provide enough money to run the services and also provide services to the poor. That's another social enterprise that has grown significantly. And we look to implement more of these social enterprises, because I can tell you that development assistance is going to be stagnant for now at best, and maybe over time, as the countries we are working in move into low middle income status, is going to decline. So we must also develop instruments of resource mobilization that still continue to close the equity gap, but less and less reliant on donors over time.
Thank you for that. So, I mean, I started with this context because I feel like so much has happened in the 10 years we've been here. And I think a lot of people heard, especially outside of Africa, that aid was being dramatically reduced, especially by the United States government. And I think people went into panic mode. And so I really wanted to hear you talk about all the really constructive things that are happening, what we're thinking about. And I think one of the things I know we're working on is working with 5 or 6 governments in Africa and how to do their strategic planning. Because as you've said before, the health system that was created by donors was all siloed. It wasn't primary health care. It wasn't the most efficient use of resources. And so, as we said in our title, there's a revolution coming. And what does that look like? And what are the opportunities?
So what has happened over time is that we know that because largely what you might call development partners were focused largely on diseases that were likely to be a threat to global health security, meaning that 98% of institutional development assistance through the governments that we know are largely involved in development assistance, the US government being the lead of them, followed by Germany, UK, and others, was focused on key areas. 1, HIV. 2, tuberculosis. 3, malaria. 4, childhood immunization. Because when you immunize children large scale, it's a public health benefit, because then you reduce the incidences of measles. And therefore, you reduce the threat of measles spreading to countries that don't have that threat. You reduce the incidence of diphtheria and the tetanus and all these others. So most of this money, I would say 98% of it, was focused on these areas. Childhood vaccination against infectious diseases, HIV, TB, malaria, and there was an element of maternal health, because by taking care of mothers, you took care of children, and you encourage mothers to take children for vaccination. But that meant that because of the accountability requirements that were provided on this money, the money was coming into vertical silos. I'll give you an example. You went to a normal health center in a rural area in Malawi that actually receives mothers when they're pregnant and healthy, they're coming just for checkup, receives children coming in for pneumonia or for this and that. But on the side was a well-facilitated clinic that was funded by US government. And this clinic had a better laboratory system than the health center that was in the same compound, had a better data system than the health center that was in the same compound, had better trained health workers than the health center that was in the same compound. These, you access them through the same gate, but if you had HIV, TB, malaria, or this, you went to this side. But if you are a regular community member coming for your services, you went on this side. Now, what that meant is that it kind of over-concentrated resources in a vertical area of disease. Yet, we know that these other conditions, maternal health, hypertension, diabetes, cancer, were rising. Today, 50% of all hospital admissions in Africa have to do with hypertension, diabetes, or cancer. None of them is a beneficiary of aid as we know it today. 37% of all the deaths are from cancer, hypertension, and diabetes. Yet, none of these is a beneficiary of the currently structured development assistance. The normal we know, facts tell us that even when you actually do a very good job of keeping somebody who's living with HIV healthy, they then die of hypertension or die of a cancer or other because their care is purely on HIV, is not holistic care. So what this has done, Bob, is to provide us an opportunity to integrate the health system. So we as Amref are working with countries to see how to integrate better the health system while still ensuring that they can maintain the specific services and needs of those people because they have their own specific needs. Those people living with HIV, the issues of stigma to deal with, and therefore that must be handled within an integrated health system. There are issues of ensuring that somebody with tuberculosis, there is good infection prevention and control so that if there is integration, the person with tuberculosis is still handled in the proper scientific manner of infection prevention and control as you would somebody with cholera or something else. So integrating this system, we have taken health workers who would have actually been fired after the end of USAID programs and reintegrated them to the system by reducing their salaries because they were also paid more than the regular health workers. So all these areas is an opportunity for us to integrate the health system and to serve the individual through a holistic primary health care. The next opportunity is to ensure efficiency in the system, that governments are being told now the dollars have reduced and therefore you have to now focus on getting more health for the money, not just more money for health. And this is another opportunity to improve what we call efficiency and effectiveness of the health system. And finally, is that we have an opportunity for governments to own their own data, because I can tell you, colleagues, that when these siloed systems were happening, the data for TB, the data for HIV, the data for malaria was owned by the funding government or the funding institution. Having this data now come and get integrated with every other data is an opportunity for sovereignty on health data as much as it is sovereignty on the primary healthcare agenda.
Thank you. So we're nearing the end of 2025. A lot has happened. I want crystal ball. What is 2026 like? I think it's going to be a challenging year. There's a lot still going on, a lot of uncertainty. Love to hear your thoughts, how people can help, and what the challenges that we're going to be facing.
Wow. If I had a crystal ball, and if I would actually tell the crystal ball what to do, I would say we want respectful partnerships that put Africa's health needs at the center and therefore built on a foundation of trust. Because I think the challenge we've had, Bob, of all these broken and siloed systems is a reflection of lack of trust. Because I know if I give you this money, I don't trust that you deliver my outcome. Therefore, let me build a system that has locks on every door and window so that there is no leakage at all. There is no integration with other systems. So I would say that we want to build, first and foremost, we want to build trust. That would be what I would ask my crystal ball to do. The next thing that we want is leadership of African governments. I think that part of the challenge has been that there is a feeling that the reason the development assistants and development partners have managed for so long to control the agenda is because of poor leadership on African government themselves. Now, we can demonstrate that if African governments are strong, the health ministries, and we do that, a lot of that as Amref to strengthen the leadership and governance capacities of health ministries, is that they're able to say no when they need to. And they're able to say, this is how we work here, and we don't fit to this strategy, one plan, one M&E framework. then we are sorry, we'll not work together. And they should be ready to say, we don't need that money unless that money is aligned. And we've seen some governments we work with be able to do that. So that's the other thing I would want to see, that we want to see leadership that is centralized on the people who know exactly where the shoe hurts most. The next thing is that we will move out of crisis management and move to more to systemic capacitation of primary health care for universal health coverage, that we will build a health system that is not constantly in crisis mode, that's resilient enough, as they say, for peacetime and for wartime. That's the other thing that we must do. The next thing is we have to see, I would want to see a future, and this is what we are looking for, where domestic investments are well matched with external aid. That external aid is coming to support the national financing strategy. It's not coming as a separate pillar, it's coming to support the national strategy. And finally, that we would have equal, equitable donor to country partnerships that are built on equal collaboration and respectful partnerships. I think that's what I would ask my crystal ball to say. And therefore, that means that's my vision. And that's what we are working on as an organization, where our strategy is absolutely aligned to those future visions and dreams that have aligned.
Thank you very much for that. I think that I like your crystal ball. I like what it's saying. Nicole, I know there's probably a bunch of questions, and I will let other people jump in so don't have to listen to my voice any longer.
Thank you, Bob. Thank you, Githinji. So I guess a first question, today is December 1st, which is World AIDS Day. And you mentioned HIV/AIDS a couple of times briefly, but this is actually the first World AIDS Day since 1988 that the US government is not commemorating. There's some UNAIDS data now that's saying that if we don't resume the full scale of prevention efforts that have been suspended, in the next 5 years, it could lead to 3.3 million new cases of HIV. And even here in Kenya, there was some data over the weekend that showed the first increases in new HIV cases in 3 years, as much as almost 20%, which is tremendous. So in that alarming context, I'm sorry, you ended on an inspirational note, and now I'm taking us a bit backwards. But just wondering if you could dive a little bit more into what the impact on HIV/AIDS has been in particular, and what you're making of some of this new data. And then I promise we'll ask at the end one more positive, forward-looking question.
No, I think that the HIV challenge is a good example of the challenges of our healthcare system. When we started the HIV response many years ago, it was based on a rights approach. It was based on giving people the power to make decisions and to prevent themselves from getting infected, including mother-child transmission. And then over time, the governments, whereas the governments wanted to continue empowering their people, the development partners felt strongly that HIV/AIDS should be reclassified into a chronic disease. And therefore, it shifted all its science and data and resources to actually just three things. One, testing, meaning ensuring everyone knew their status. Secondly, ensuring those who knew their status were on medication. And third, that their viral load on testing was undetectable. As you notice in those three, there is no prevention strategy at all. And that prevention strategy that was there before, keeping people safe, for example, through education, using the school system, for example, to educate young people about their sexuality, that was completely dropped. So now the strategy we have now, if we abandon treatment, as we have done, because now the commodity supply is going down because of the withdrawal of assistance, if you abandon testing for viral load, because the viral load was assisting us to ensure everyone is consistently on medication. And we used to say, if undetectable, it is untransmittable, meaning that the focus has been to ensure that even those who are living with HIV have undetectable viral load. Now, viral load testing has been a victim of the AIDS cliff. So many governments, because they can't afford to continue, they have dropped viral load testing. They have only focused on ensuring maybe some people have, the people have some form of treatment. Now, if you're not doing viral load testing, it means that the people may not have suppressed viral load and therefore can infect others. And that's what we are seeing now because we have dropped the prevention and health message entirely. The use of condoms is not talked about at all. The use of safe behavior is not talked at all about. Rights and decision making for young people have been taken over by governments and the religious movement. So this is the danger we are facing, and HIV is going to be the first victim of this withdrawal. And we are already seeing rising infections, and the challenge is that the biggest increases in new infections are in young people between 15 and 24 years. That's a disaster. So we are putting an entire generation at risk, and therefore communities know what to do, and with resources, the community would be able to design the tools, a solution that would help reverse this tide.
Thank you so much. I have two questions before we end the call, and you've helped pivot perfectly to the next one. Was going to ask a bit more about young people. You just mentioned that they are getting new infections of HIV at alarmingly high rates. I'm wondering broadly what the role of young people and youth-led, youth-serving organizations are in this vision for greater sovereignty here in health across the continent. If you could talk a little bit about that role and how we're working with some young people and youth organizations.
You see, the challenge we are having for young people is that we have policies that are not fit for purpose for young people. And these are the policies that we are working with young people to change, because the best person to change a policy is the person who is most affected by it. It is those who lived experiences of a failed policy who must be in the front line of changing it. And the policies we have right now are made by people who don't understand the young generation. For example, we know that policies in many countries don't allow comprehensive sexuality education to be discussed in schools because the older folk say, well, if you talk to young people about sexuality, you're encouraging them to go and have sex. So it's an ethical dilemma for the older people. Now, it's only the young people who can step forward and say, we know what we need. We are going to mobilize our parliaments. We are going to mobilize our local leaders to change the policy to allow unfettered access of reproductive health services to young people because they know that's what they need, and overcome the ethical and moral dilemma that the older people are stuck in. So we are working with young people to identify these things. The challenge we've discussed now with HIV is that young people are victims of this because within the countries where they live, access to condoms is fettered by policies. Because the older people who put the policies in place do not believe young people should have access to condoms because they should not be having sex in the first place. And therefore, when they actually have exposure to transmittable viral loads or people who are living with HIV who can actually easily transmit it, then the young people are the first to be affected. So this is how we're working with young people, for them to drive their own policy changes. And this also includes the biggest challenge in Africa, which is teenage pregnancy, where young people are not provided with the tools to protect themselves and to make decisions about when they want to get pregnant. So young people are the drivers of that. And therefore, that's how we are working with them at national level and also regionally as well.
So I have one more for you, and then if we have an extra minute, I see there's a hand up from Marike, but we received a question for the folks that are on this call today. If there's one thing today that you could ask for help, if there's one thing that the supporters on this call can do, what would you suggest? How would you suggest directing their investment?
I would say that the most important thing in this shift to sovereignty is trust. I would say that give with trust. Say, I know, look at the impact, look at what we are doing, and say, I trust you to know what is right for the continent. I trust you to know what is right for changing the system for the future. I trust you to know what is right for teaching the people how to fish rather than just giving them a fish. And I'll give you an example. Of course, this is no parallel to anyone here. But when Amref Health Africa received a big grant from Mackenzie's Court, we knew that the best way to spend that money is to build and capacitate a university for health workers to ensure that Africa will train its health workforce across the continent, will train them using available knowledge in our programming, because we are programming on these areas I'm talking to you about, so that when you graduate a nurse, they know what the challenges are for the mother in the remotest corner of their country, because they're being trained with the context specific to their continent. We invested this money in the university. We've just launched the university with a capacity of 10,000 nurses, midwives, serving the continent of Africa, including creating an environment for them to learn, because we knew that was necessary. But if we had gone to a donor who did not trust us and say, no, my money is only for the following things, but by trusting us, we're able to make something that's going to outlive all of us on this call. So trust is what I would ask for, that give with trust, and we, in return, we will prove that you did the right thing by trusting us, because you'll see the impact will actually be founded on the solutions that the communities themselves, who we are representing on this call, know exactly what needs to be done. And that's where the investment will be going.
Fantastic. Thank you so much. With
I think
3
we're out of-
minutes.
I think we're maybe out of time because Githinji has a hard stop.
Okay. Well, that was a good
So-
note to end on.
Yeah, I felt like that was a perfect ending. So sorry about not being able to answer all the questions. Well, thank you, everyone. Thank you.
Bob, I think Mariake's hand has been up for so long. I'm happy to take a minute just to.
Are you sure? I don't want to keep you from other obligations, of course.
Your hand has been up for so long, so I just
Yeah,
want to
it was getting.
So I'll make it very brief. Yes.
Okay. So very quickly then, I'm only a simple communications manager, not a medic. But I think I heard you say that we managed to do something great in Ebola in the beginning of the conversation. Can we claim a success in this? I think you said that the virus does still break out, but it does not travel anymore. Is that something we could celebrate a bit more loud, maybe publicly? You know, blow our own horn a bit more about this, if this is the correct expression. Did I understand this correctly?
Yes, you did. And I think what we can celebrate is community-based surveillance, that the virus is noticed, the outbreaks are noticed much earlier, and therefore the response is much earlier. And that's community surveillance is a building block of global health security. So that's what we should celebrate. We do celebrate, and we continue to celebrate. And in addition, it is the presence of Africa CDC, which we work very closely with as the continental disease response and surveillance body. Those two have actually enabled us to respond much earlier and avoid the virus traveling beyond borders. Thank you very much, Marieke, for that question. Thank you very much, everyone.
Thanks, everyone.
Thank you, Bob, for your moderation and Nicole. And thanks, everyone, for your time.